All right. Well, welcome everyone. We are so excited to be here today, joined by Stephanie Hartsfield for this cross-sector care coordination training. We heard from many of you that this was something of interest that you would wanted more information on, and we are very lucky to have Stephanie be able to lead us through a session today. I think before we get started, it would be great if folks could introduce themselves maybe in the chat, just your name and where you're from. That would be wonderful. And I think with that, I'm going to hand it over to Stephanie.
Great. Thanks so much, Catherine. I'm going to go ahead and share my slides. Thank you all for being here today. We're so excited to have you. And we're going to take some time to go through this training together. And again, as Catherine said, I would invite all of you to share your screens if you're willing to and not multitasking too much. What we're going to try and do throughout this is have it be a little bit of a conversation and somewhat interactive as much as we can on Zoom. Feel free to unmute and ask questions as we go through today and different things like that. So I'm really excited to be here with all of you. So my name is Stephanie Hartsfield, and I'm a consultant with the PHIL team. And I'm glad to hear that everyone was interested in cross-sector care coordination because it's interesting and it's different than just a lot of the care management or care coordination that we do individually in each of our organizations. So just to start off, our objectives for today is we're really going to look at learning how coordinated cross-sector care coordination can reduce some of those barriers to health care access and can address the social determinants of health that we all know and love at this point. We're going to try and understand the facilitators and barriers to high functioning cross-sector care and identify strategies and tools for efficient team-based care. And hopefully when you leave here at the end of the hour and a half, you'll be able to list some strategies to improve care at a regional level. And we're going to talk about what regional might mean to you because we have the Northwest and Southwest region as far as the CPI collaboratives are concerned. But that means a lot of different things to different people, and we can collaborate in different ways. We're going to talk about that. And I just want to say I have worked in training and organizational development with different populations for over 20 years. I've also been in direct service with complex populations, working with folks who have disabilities and in housing, all different areas. And this is really a passion for me, and worked in different complex models in various states. So I'm excited to be here and just want to say that I do understand and appreciate all the hard work that goes on, whether you're a manager, you're in direct service, or you're putting together the policy, the funding, and all of this, that none of it's easy and it's all important. So thank you for the work that you're doing. I wanted to take a minute to talk a little bit about how we got here. And by how we got here, I kind of mean, why is cross-sector care coordination and teaming such a big deal right now? And it may feel like it's all we hear about, or interdisciplinary care coordination is a lot of what we hear about right now. And one thing I do want to acknowledge is the CalAIM initiative is really well done. From my perspective, I will say it's huge, it is complicated, and it may feel a little bit like there's too many things going on. There's a lot of things to understand, and it keeps changing at a rapid pace, or not even changing, but as each 6-month period goes on, something else is coming online. But I really, as far as innovations go, it's really well laid out, and nothing's easy to absorb all at once. But I did want to take a minute to just kind of go backwards in time. What you're looking at here, this is something from the Bay Area Health Institute, and it's been around, I think, since 2009. I can't exactly, 2015, it says down there in the citation. But people have been talking about social determinants of health and the health inequities for a while, and it's been difficult to figure out how we work them into our existing system. And I think we're still figuring it out. That's okay. It takes a long time to figure things out. So this is just a nice diagram to look at, what does upstream health mean? What is downstream? And where does it all come together? This isn't the answer. It's just a diagram of it. And part of the perspective I just want to mention is just around the fact that 10 years ago, a little over 10 years ago, is when the Affordable Care Act came into place. And you might think like, where are we at after 10 years? How much have we done? And I'm going to move on to the next slide and talk about that. We've actually done a lot. Thinking back to 10 years ago, some of the first things that we started with in the Affordable Care Act were just having primary care practices and healthcare systems get onto electronic records. So 10 years ago, we were all still going into our doctor's offices and we had paper charts and all those racks and racks of files, and that was commonplace. So we started with, let's just get everyone onto electronic health records. And that was really hard and it took a while. And then it was getting the healthcare marketplaces up. And when you think about things from a federal level, you can have a great idea. You have to get it passed. And we know that's a hard thing. And then, Medicaids are run differently by every state and then getting them implemented there. So these are kind of Herculean tasks. So it's been 10 years. Everyone's on electronic health records now. We've got insurance marketplaces that are working pretty well. And then you start looking at how do you put it all into practice? How do you start doing some of these things? So you'll see like in that last slide, that was 2015. So 5 years later, we could start talking about how does some of it work in practice? How do we acknowledge that, yeah, we still have to work with the community organizations or people still don't have food, and how do we put it all together? And what I'm showing you here on the screen, it's okay if you can't read every word or it doesn't make sense to you, but I want to acknowledge that we all know about silos. We all work under different policies, different payment systems, and ultimately the goal of the Affordable Care Act and all of this health reform is we're working towards all payer models. We're changing the way healthcare is paid in the country. And now, like with things like CalAIM, we're also working towards including others in what we consider healthcare. We're including community-based organizations. We're including behavioral health. We've started to expand the vision of what it looks like when we talk about healthcare, which is great. And do we have all the answers? Definitely not, but we're figuring it out. So this little 3-column diagram is just showing that we've got to figure out how do we change how we pay the people providing services and make sure that's somewhat equitable. How do we figure out how we collaborate with each other and still deliver good care? So those are some of the ultimate goals that we set out with 10 years ago. We've come a really long way and we still have a long way to go. And so we're learning and we're doing it. And I'm bringing this up. A lot of you already know this. Some of you may not, because when you're busy providing care every single day, you might be an MD, an RN, a social worker, you might be helping people find housing, whatever you're doing, you probably don't have a lot of time to study the policy and the financing changes that are happening, but they're impacting you now. You may be a policy wonk and just love to look at this in your spare time. Good for you, great. But it's impacting what we do and how we do it. And it's why we have all these changes happening and why something like CalAIM is huge and hard to understand. And ultimately it's going to be great, but there's a lot of nuance. So I'm just kind of adding that big picture perspective, and then we're going to keep kind of narrowing down. And the bubble on the side is I do want to say that I think you all know we're going to be talking about communication. We're going to talk about how we share information to ultimately get the best care for the people that we serve. A huge part of that is data systems, the infrastructure. How do they work? We're not going to talk about that today because that would be a whole session in itself. And that's a big part of this. And also just financing policy, payment and billing efficiencies. Those are all going to be a component of this. And you're talking about it. There's plans for that. Again, that's another whole session in and of itself. And a lot of that, there's already structures in place. I think for billing and payment, there's some really clear guidelines. And we'll be talking about what's already on the partnership website, what's on our Phil website for resources. So things that are already in place for kind of the nuts and bolts and the what's. There's a resource slide at the end. I'll definitely point you in the right direction for those kinds of things. But today we really want to focus on the little less nuts and bolts, kind of the how and the why of doing things to really help work across those sectors. So, all right, we're going to take a minute and we're going to get to know our population here because we're really talking about population health and cross sectors. This is not all of you, so let's find out who's in the room. We're going to launch a poll and see who we've got. So which sector of the health and social care system do you represent? So we've got, kind of an equal split between managed care, housing, and social services, which is great. I think that's really nice. And then interestingly, so we've got some people from city and county and primary care, and then hospital at the smallest percentage. So that's a good mix. I think it's a good mix. I was surprised there for a minute to see our smallest sector is in the healthcare and primary care. But that's good to know. Okay. And then, sorry, I'm looking at my other screen to see this, you can tell. And then what role do you represent in your organization? We've got no nurses, interesting, social workers, no case managers, care managers, no PCPs, okay, finance, administration, and other. Ooh, might have to, okay, I have to ask about that. If anyone wants to chat in, if they're an other, what they are, I'm very curious what some of our others are. Okay, that's a really interesting mix. And then what region are you representing? And we've got no one from Del Norte, Humboldt, 13 Mendocino, no one from Lake, Marin, okay, no one from 2 counties, 3 counties, and a few from too many to count. I had a feeling we get several from there. Okay, all right, well, that's a really interesting mix. Great. Thank you for doing that. I know you're doing that on a lot of the calls that you go to. And here it's going to be important. We want to keep that in mind when we start looking at who our cross-sector teams are and who we're working with. So I appreciate you doing that. This is also going to be important to start thinking about who shows up, because we are all in a CPI together, Collaborative Planning and Implementation Group for PATH. Stop me if I use an acronym that you don't know. I really try not to too much. And how we overlap and work together. But also one of the next steps that's going to come up with the CPIs that Phil is running is we are going to do some asset mapping. And I think that'll end up being really helpful to you. So we're excited about that next step, and that's me coming up soon. Okay, so that's who's here today. I'm surprised and interested to see that review. Okay, so now let's talk about building a team and who our teams are going to be and what it's like when you're working with different people. So my first kind of question to all of you is, when you look at this picture, I'm kind of curious where your eye goes. And here, if people want to unmute and just shout something out, that's fine. What do you notice in this picture? What are you drawn to? Feel free to just say anything.
Bridge.
Okay, great. What else?
Waterfall.
Cave.
Waterfall. What was the one after that?
The cave.
The cave, right. Okay. Anyone else?
We saw Danielle put in a chat the moving water. We also see different speeds of water and streamlining, a nice path.
Awesome. Okay. Anyone in the last ones? Okay. That's fantastic. So thank you for those who kind of shared in. That's terrific. So I use this picture often when I want to talk about just kind of different perspectives. So one thing that's really important to acknowledge when you start out for building your cross-sector team or building an effective team is to just stop first thing you do and recognize the fact that you're all coming in from very different perspectives. So whatever those perspectives are, we're coming in from different backgrounds, different areas. We're coming from different organizations. We're going to talk a little bit about organization cultural competency today and what that means. The reason I ask people what they see in this picture is everyone notices something different when we first look at it. And to me, that's an example of what we see when we're looking at a patient or a client or a person, or the way that we approach a problem or a situation is really, this may seem really simple and obvious to you, but when we are working at the fast pace that we have to in healthcare and social services and behavioral health, we sometimes forget that everyone is seeing the situation differently. And whenever I ask about this, we always get different answers. And I'll say, like, I always forget, I didn't even know there's a waterfall in here. So I keep missing the waterfall. Someone said waterfall. I'm like, what waterfall? Right? And that's important because I need to recognize that. We can't forget it. I'm obsessed with the cave. I want to know what's back there. I want to know more. So I guess keep that analogy in mind when we're looking at our complex individuals that we work with or the organizational challenges, that everyone is not coming to this from the same perspective, even the same rules that they have to work with, the same financing. There's a lot of challenges that we have to approach. And one of the common things when teams come together is you'll hear sometimes people say, like, they don't understand how busy I am, or do they even know how much work I have? And I think the answer to that question is no, they don't know, because they're not in your shoes. And a lot of us we're all really busy, and we may be busier at different times, but until we acknowledge it or say it or ask for what we need, the other people really don't know. And we have to tell them. So that's just my first thing. We have to say that waterfall we forgot about that. That's really important. Or has anyone figured out what's behind the cave? So we have to talk about it. We can't assume that we're all looking at the same picture when we are looking at the same picture. So something to think about. So why do this interdisciplinary care, the cross-sector care? We all do really good work on our own, and we know that we're helping people, and we've got plenty of work. So adding one more meeting doesn't sound like very appealing sometimes. And, why do it? Now, some of this may seem really obvious, but we balk at it sometimes. So what really has been shown to work and proven is that really it ends up allowing for enhanced access to care for the people that we work with. The way that certain people access care can be different. Ideally, we hope that everyone is going to their primary care. We hope everyone has a primary care. The people in this room all know that not everyone has a primary care or goes to them, so they might be more comfortable seeing someone through their home, or whatever the reason may be, or out where they live in the park. We know that. So we have to figure out how is it that they can access care. Improved quality, safety, and reliability of care, enhanced health and functioning for those with multiple chronic conditions, and more cost-effective care. And not everyone sees this in the beginning. We'll look at that later with an example, but it really can be more cost-effective in the end. We just have to hang in there for the long run. And improved client experience. Really, for them to meet them where they're at, it makes a big difference. We know what's easiest for us, but we really have to think about what's easiest for them sometimes, especially with our most complex and vulnerable folks. And then the last point is not from the article that I'm citing from the Institute for Healthcare Improvement. It's just add in there, but it really, over the long run, reduced burnout for all of us. So we know this is a big factor, but the more that we work together and see where those intersections in our workflows are, we can help each other. We can reduce that burden and these high caseloads and the amount of work we have by just working better, working smarter, some of those kind of cliche terms. Okay, so this is one kind of team performance model. There's a lot of these out there, but I want to kind of frame a little bit of a cross-sector team in some evidence and some looking at these phases of a team, because when you come together, when you form your team and look at who's on it, again, with acknowledging like the perspectives that we're all coming from different organizations, we're all coming from different workloads. We also really want to acknowledge that you can't come together, sit at a table, look at your master information file, start talking about clients, and it's all going to work really well, because it's not. It might for a little bit, but it will fall apart. We have to stop and acknowledge process and acknowledge that we are a new group of people coming together with different perspectives and all of that. This doesn't have to take a long time. Sometimes groups come together, committees, whatever it is, and they spend way too long on process. I'm the first one in the room when we work on a vision statement and a mission statement for a year. I have been in those groups and I will lose my mind. I really cannot do it. So that's one extreme. But then the more common, the other extreme is like, let's just get down to work. We have too much work. Let's just get going. But that will end up kind of squashing your purpose in the end. So take some time and really look at this. And I like this model. There's a link in here. You'll get all the slides. This is one that's available online. But these are pretty common phases. I would add an arrow at the top because, everything's iterative. You're always going to have people kind of coming and going. You always want to check in on process. But when you first come together, there is a small orientation. And I love that it says, why am I here? Because people are thinking that. And you want to acknowledge, like, some people are like, oh, why am I here? One more meeting. Other people are really excited. They get it. But you really want people to feel safe, to understand why they're there. And throughout all of this, one of the biggest things is psychological safety. You have to stop and really think about the purpose here and build trust, which is step number 2. If people are going to feel safe communicating, sharing their ideas, talking in a group, and all of those steps are critical for the success of this. And so creating that safe and trusting environment, it is important. And those are those first steps that have to happen. Step 3 says goal clarification, but it's in the middle that I like. What are we doing? What's our purpose? Let's make sure we know. And we're not just necessarily following the steps that CalAIM set out for us, or we're not just meeting the criteria of ECM. What are we doing together? Are we making sure that we're helping everyone to hit those targets they need to, and that when they go back to their home organizations, they're also accountable to metrics or audits that they need to be accountable to, while also fitting, into the CalAIM framework. So you've really got to talk openly about that. And that's, again, that perspective, and really figure it out. And then how do we do it? And that's bringing those processes together. Then keep checking about the implementation, performance, and going back. So it's being very intentional about what you're doing and making the space for the conversations and that safe environment. I'll just pause there. I don't know if anyone has questions, but it's not always comfortable, but it's necessary. I'll say that. Okay. So I'm going to pause for a second. So this is why I was a little bit surprised by who is in the room here, and a little bit not surprised. Probably the people who have time to come to this kind of training right now. We've got administrators and a little bit more managerial staff here. That's okay, because actually it's important. When we start this kind of work and you're diving into it and it's new, there's going to be new workflows and time commitments. It's really important to have executives, administrators, people on board and supporting this. So I'm happy to have folks here, but you're also need to have the ground staff, the direct service really here. And it's really important to take some time to acknowledge, the nomenclature, the language that we use. And I'm going to talk about cultural competency. So most of us, I'm sure, have had training on cultural competency in the traditional sense. This is where I talk about organizational cultural competency. Each of the types of organizations that we work in have different cultures. They have different languages. We honestly speak different languages. Housing speaks a very specific language. They have HUD acronyms or PSH acronyms and housing terminology and language. And, hospitals speak a language, primary care speak one, behavioral health. We all have 50 to 10,000 acronyms that we use that are different from the other ones. And when we walk into a room and we're together and we all think that we understand each other because we're all there for the best interest of the clients that we're serving or the people we're serving, we, I think, often assume that we understand each other, and we don't. And there's always someone in the room who's too afraid to ask and say, I don't know what that word means, or what's that acronym? And so I do think it's important, again, for that psychological safety, for communication and trust building, to be able to say, does everyone understand what we're saying? What term do you use for this? Or what are we going to use? To just create that space up front. And when you layer this kind of organizational culture and language on top of the more traditional cultural competency, it can get very messy or complicated and feel even less safe or comfortable for some people in the room to speak. So really being intentional about how you set up your team and creating that safety is important. So I just want to say, if you look, so looking here at this example, on the left-hand side, if you look at the terms we have here, so under providers, and I'm going to use the term providers, there's a bunch of different terms, care manager, case manager, care coordinator, you can see them, service coordinator, social worker. I think that if I asked each of you that are on the call today to say what those meant, you would each give a definition that was different, vaguely similar, but different. So some people think a care manager must be licensed, has to be an RN. Some of you wouldn't say that. You know, a case manager can be completely different depending which sector they're working in. Care coordinators, again, also are different. Service coordinators to some are definitely a housing resident service coordinator, which is a HUD designation, but it can also be something somewhere else. Some industries don't recognize care managers if they're not RNs, but others, of course they do. They're all doing similar work. And then social workers, some people think I've heard people say case managers do the exact same thing as a social worker, or they'll refer to a case manager as a social worker. And that might not feel good to a social worker who's licensed and has gotten their credentialing, or to a case manager, you know, so you get it. There's a lot going on here. So I think, again, establishing what things mean to different people. And going back to the top, provider, to a lot of people in healthcare, provider is a clinical provider, a licensed provider, but also in other sectors, a provider is anyone who's providing services to someone in need. It can be social services, it can be anything. So outside of your sector, you may not know what a term means. So I would say check in. And just make sure when you're working with other people and when you're working in this safe space that you're going to create. And on the other side of that, it does matter to take the time to say, on this right-hand column, what are we going to call the people that we work with, these human individuals that we're serving? This can be, you know, triggering for some people. People have emotions around this. It's important. It's too easy to say, like, whatever, you know, client, patient, member, whatever we call them. That's easy, but it's not healthy and it's not safe. So it's important when you bring this group together to say, it seems like we all use different terms. Can we agree to what's comfortable for all of us, since we're all going to be working together a lot? And acknowledging that when you all go back to your own organizations, if you work for an MCP, you're going to have to use member on paperwork. And if you work for the hospital or primary care, you're going to have to use patient. Or so it's complicated, but again, to establish that trust and safety, it's important to acknowledge the differences. So just setting that up. Okay, so just some core components when you're thinking about building your team and who's going to be on it, some things that you really want to think about as you go into this, because some people may just assign, some organizations may assign the person who are like, oh, this person's just in charge of our ECM or all Calium things. And it's great to have someone overseeing some of these new benefits, the new waivers, all these things. That makes sense because files have to be named a certain way. There's a lot of minutia to follow. So it is great to have someone coordinating in charge of things. But is that person the right one to be on the cross-sector care coordination team? So really start thinking about those kind of things. You're going to need someone, we'll talk a little bit more about this later, who has access to client information, person information, but you need someone who's open to change, is willing to be flexible, talking about how to define a shared purpose, really work with the team members, because that's how this group is going to move forward and make decisions. Someone who can come in and figure out clear roles and responsibilities as a team member. So some people come in and say, this is what I do in my organization. I can only do this much. I can't do any more. That's okay, you know, that they know their role, but what is their role on the team? They do have to have some participation as a member of a cross-sector care team. And that may be well within the confines of what they do in their organization, but they have to be able to contribute in some way. So just someone who's prepared to go into it knowing that. someone who's consistent and reliable. And most of us are when we go to this, but really when thinking about building your cross-sector team, when you think about as an organization who's going to be on that team, it should be the same person. Maybe two people can switch out, but it can't be a rotating group of people. If you're a home health organization, you can't be like, oh, whichever nurse is available. It just won't work because you're building trust, you're building safety, and you're going to lose a lot of productivity if you have to keep catching someone up. So really think about who can be consistent and reliable, and let's have trust there, because it's going to help with this trust that you're building over time. And then people who communicate well. And so you know who that is. Some people are amazing nurses or whatever their role is, social workers, but they're like, communication's not their strong point, or they're not, whatever. That's not the right person, because it's going to be hard and a lot of communication. Okay. So time to talk about our person that we're going to work with. We'll use the word person here. I'm going to use all sorts of different terms because I've worked in every industry, I think. But I think that this works better if we have an example. So I'm going to introduce you all to Maria. Maria is based on an actual case study, but to protect the innocents, all important identifiable information has been changed. So this is Maria. She lives in San Rafael, California. She lives in a HUD affordable housing site for older adults and adults with disabilities. She is 57 years old. She receives SSDI as her main income source. She lives with her mother, Clara, who's 83 years old and pretty frail. She's an easygoing person. She drives and she is pretty independent. So that's good. She does wear portable oxygen most days. So that's what we know about Maria at this point. So what I want to ask of each of you, I didn't know that. Okay. Is a couple things. For right now, you don't need to chat in or talk. I'm going to give you a couple minutes. I just want you to think on your own or write it down on a piece of paper at your desk, wherever you are, is kind of why Maria. So she showed up on our complex care list. We got the list from the MCP, from Partnership, of our complex individuals eligible for enhanced care management. And we're kind of thinking about, she seems like she's doing okay. So why Maria? And my questions for you to think about, just to take a minute or two to think about, is if you're going to sit and talk with her, what 3 things would you most like to know from her, to know a little bit more? And why do you think she is on this, the MIF list, member information file, I might be saying that wrong, as a complex patient? So take a minute to think about that and just kind of jot it down, and then we can share a couple answers. Okay, so I most often do this live, which is my favorite way to do it. And so I look for people to be looking back up and things like that, to know when people are done, but people feel like they've had enough time. Yes. Oh, I thought I had not. Thanks, Laurel. I appreciate that. I'm actually going to stop sharing for a minute. I think that'll make it better. All right. So now if people have written things down. Oh, Noelle gave a thumbs up. Thank you. So now let's share. So I am curious. So people, just come off mute and share if you can, or you can chat in, but I prefer to make it a conversation. What 3 things do you want to know? If you had some time to talk with Maria and sit down with her, what would you want to know?
Why is she on oxygen?
Yeah, that's a great question. Yep. What else? There's no right answer, by the way. Yeah, Noelle.
Does she have access to enough nutritious food?
Great question. Yep.
Noelle, you're muted.
Is the housing in her name with her and her mother, or is it mother's housing?
Fantastic. That's a great question.
I'm curious. I think she's 57. The first slide said 57. The second slide said 47, but I'm voting 57.
Yeah, she's 57. That was an error.
I'm curious as to why a 57-year-old's on SSDI.
Right.
And is that related to the oxygen?
Okay, great. That's a great question. What else? Anything else?
What are her struggles? What does she struggling with?
What is she struggling with? Yeah, fantastic. Okay.
Is the oxygen new, or is this something she's been working with for some time?
Yeah, yeah, fantastic. Does she have access to transportation to get her to healthcare visits? Great question. Yeah. Great. And I saw someone about, does she need help budgeting finances? Yeah. Okay, great.
Is her mom insured?
Was her mom insured? Oh, great question. Yeah.
And does mom have income?
Yeah. Right. All good questions. Great job. Is she a caregiver to mother? Interesting. Good. Yeah. Does she feel safe in the neighborhood? Oh, I love that. You know what? That's one of the first times I've heard that. That's great. What are her areas of concern, needs for support? Okay, you all are great. I said there's no right answers, but I always love hearing what each group says. So terrific. All right, so let's look at the next question. Why do you think that she's on the complex care list? And someone asked, does she have a primary care provider? And when was her last visit? Absolutely. Great question. What provider? Yep. So why is she on our complex care list?
If
What do you
I
think?
if I was making up a scenario for her, she is frequently being hospitalized because her mother is a smoker and she's oxygen dependent, and it's causing her to have COPD flares, which is making her go to the ER frequently for undertreated COPD.
Creative. Love that. Okay, what else?
Can I add that she lives on Lincoln and she's getting all the traffic fumes?
I don't know San Rafael enough to know that that's what the traffic fumes are, but that's better than the 87-year-old frail mother smoking. Like,
Right.
Which is
So
Which-
true.
I'll add
No.
both. I can have both.
So true.
That's great. Okay. Yes, Amy is thinking visiting 6 ER/ED visits a month. Okay. That's from Danielle. Perfect. Any other thoughts on why she showed up on the list?
She's not oxygen compliant.
O2 and chronic pain, I see, or oxygen compliant. Great. Great. Anything else?
I would consider her at risk for homelessness because she has a HUD voucher and they have to renew every year. And if at any point in time she no longer qualifies, she will be homeless.
Great. I'm gonna guess maybe where Jessica works. Okay, fantastic.
I am assuming that she's a living aid for her mother.
Ah,
Yeah.
very good. A live-in aid for her mother. Nice, Alejandra. Yeah. Okay, anything else? Those are all fantastic. Okay. Okay, well, we're gonna move on. I guess maybe we'll find out more, maybe not. I'm just gonna leave you hanging. Okay, I will tell you more, but
could we
don't
consider
know
that
it.
maybe she likes the sauce a little too much?
Yeah, absolutely. Yeah, that often is the case, and we don't know if, alcohol misuse, in older adults. She's not actually that old, but we have no idea what's really happening.
But functional, she could really
Yeah.
super functional and just go home and just have, I mean, the picture you showed was a frail adult who maybe is prone to falls.
Perfect. I can tell you're all good at your work. All right, so let's keep moving and see what happens next. Whoop, there we go. All right, so I'm not going to tell you more about Maria right now, but we'll get there. So now we've got to create our cross-sector care team, right? And the first thing I'll tell you is when you're creating this cross-sector care team, this makes sense, is build from where you are. So don't start from scratch. And the first thing I want to say is, I don't expect you to be able to read the diagrams on the right-hand side, so don't worry. But what I really want you to notice is in the upper right-hand side is that messy picture with all these lines going back and forth. That is a real kind of network analysis of an area of actually a county of different organizations, collaboratives, connecting and working together And I think that's probably similar to what a lot of you are doing right now, wherever you are. So this isn't a statement on your quality of work. People connect like this all the time. Our organizations, our collaboratives, we're all talking to each other, which is fantastic. But it's a lot of work and we're duplicating, and we're just because we're not connected in the most efficient ways. So I'm guessing that what you're doing looks a little bit like the top picture. And what we want to work towards is the bottom picture, is getting something coordinated and efficient. And that's going to happen eventually through highly efficient cross-sector care teams. This arrow right here, we hope, is going to happen a lot through your help from Phil and our asset mapping. And when I said at the beginning that CalAIM, I'm really impressed with the structure and organization of CalAIM, that I think it's hard to see from one perspective, is you're really lucky to have these facilitators for the CPI groups. Normally, you look at something like that mess at the top and you're like, oh, we have to figure out who's talking to who and how we do it. And no one has the capacity to really figure out that structure, who's doing what. It's just a lot to add on to what we're already doing. But the fact that DHCS realized, like, we need to give them people to help facilitate this, do that legwork of some of the structural work, is really great. And then the technical assistance marketplace and some of these funding opportunities, that's an extra layer that I've really never seen so structurally put in place statewide before. So I do think that's great. I know it's a lot to take on, but you do have support. So anyways, we want to get you from this top diagram down to the bottom, and we'll get there. And a couple of the tips right now that you can really start thinking about, who are the most frequent partners that you talk to when you're working with complex patients? I know you can list them off right away. And, between now and when the asset mapping is done, think about who are the organizations and then who are the people within the organizations that you go to. So you're just going to start brainstorming. Also think about, though, if you work at primary care, which we don't have a lot here right now, or if you work at a housing org, how many primary cares are also reaching out to that same housing service organization or to that behavioral health organization? And that's what creates the messiness. So that's why we have to get things more aligned. But just start thinking about who are your partners you work with. Also think about who is missing, who's not here. So someone mentioned transportation. Do you want to have transportation at the table? You might have a very centralized transportation agency that helps with Medi-Cal patients or people. So would it make sense to have them there? Is there a way that you can have a privacy agreement in place to have them at the table? Would that help? So who's missing is really important. What does the data tell you? So the member information file has certain fields in it that's dictated by DHCS. But when you get that, what are some trends you're seeing? What do you know about the people that are coming up on that file around maybe certain chronic conditions, certain geographies? Definitely look at zip codes. What do you know about the area? So it sounds like Lincoln Avenue or is high pollution, or what kind of housing's in that area. Just really look at the data in a bunch of different ways, or really think strategically about it, not just the obvious ways that we always kind of look at this for what it tells us. So I already mentioned who's the right person in an organization, and then is that the person who's coming to meetings? So, you may not have had meetings yet, you may have had meetings, but you can ask for someone different, or your manager can, whoever it is. And then what are the existing collaboratives in your region? So looking over our list of registrants just for the CPI, there's some really amazing collaboratives already happening in the Northwest and Southwest region. We've got networks of FQHCs and networks of other health clinics and primary care, and of some of the social service organizations. But if you're all talking to each other, where's that centralized part where you come together, and where is there an efficiency there? And again, the asset mapping is going to help with that. And then we also have to look at time and capacity and geographies. The other thing is that with hospitals, are there 4 hospitals in a specific region? And how do you figure out the best person to come? Because we know that complex patients in certain situations will go to all 4 hospitals. Do you have an ED care manager who's able to come? Is there a way to work that in? And what are some of the other processes or systems that are being impacted by that? That's something to think about when you look at it regionally instead of just by sectors. So there's different ways to take that on. So that's something to give a little bit of thought to. When I say looking at the data list in the traditional way, is we're often like, who are my patients? Who are my clients that I serve? Just because of time and capacity and payment, like that's who you're focused on. But you're looking for those overlaps. Where do all the overlaps occur? And the hospital and the emergency room is a lot of times where you see the most overlaps in a comprehensive list. And then you have to figure out, okay, the patients from my primary care clinic are being served also by 3 behavioral health organizations, or this home health and this housing organization. And that we'll get to the steps in that, but you're looking for the overlaps, which is not what we're typically doing. So the next step, once you kind of figure out who's going to be at the table, is you want to work on kind of a shared protocol, a workflow. And this is going to take some time. This goes back to that V of that team development process. But that workflow is when you come together, is talking about, okay, when someone gets discharged from the hospital, or whatever their major event is, what do you do? What do I do? Where are there some natural intersections where we could look to ease the pain points, look for a way to make this flow better? They're there. We just have to figure them out. This is where it takes some openness, some flexibility, and things like that. And this is going to take, I think, a few meetings and a few times of looking through some of your high profile patients or people and just kind of figuring out. The consistency around protocol is also, ad hoc meetings or hitting on certain topics. We'll talk about that this time, and then we'll revisit it later when you're having your meetings. It never works very well. You really need some consistent framing. When we go into the breakout sessions, you're going to have a sample of a cross-sector care team kind of meeting layout for an agenda, and then report out notes. And it's a way to really hold accountability so that you're following the same topics along, and you just really don't want these ad hoc meetings or topics to see how things go. And then, as I've said a few times, address some of this cultural competency, traditional cultural competency, but the organizational cross-sector competency by establishing ground rules, talking about those things you really want to talk about, and making sure people feel safe to communicate. As far as the sector barriers, those are going to be some of those, metrics, regulations, audits, things that people within their sectors have no flexibility on. Some of those just exist. So we do have to talk about those and say, I can't wiggle on this one at all, but I can here, and really talk about that. So that's like, where are things just out of someone's control? And then you also want to talk about how can you support each other's pain points. There are going to be different points in time where someone says, right now I'm maxed. I have 3 people that lost housing out of my 10. That's lower than all of you have, but I can't do anything more this month. And whereas someone else might say, I'm okay right now. I can help with this, but you're really going to have to look at where you can support each other and how that fluctuates over time, or look at it in the process. It's just going to be an ebb and flow of a system. And the last point is just that we all know this, but just again, acknowledging it, is that our systems often move more slowly than the client's needs. Like the TARS, getting that authorization may take more time than what a client needs for, getting that support. So talking to each other about, where is that person at right now? We're waiting for that to come in. You're still providing the services, but we're waiting for the authorization for someone else to bill. How are they doing? We don't want them to slip through the cracks, the proverbial cracks, during that time. And we can be frustrated and really complain, or we can just figure out how to support them in the meantime. And it's not great, but we just have to acknowledge that this bureaucratic system sometimes moves slowly. And just like the Affordable Care Act, eventually it'll get better, but we have to keep doing it and finding the ways, like maybe we'll come up with a way to streamline that process, but we're just starting to test it now in California. So it's not going to be perfect. And you know, those of us who work, you know, in direct service, we may have really good ideas of how to fix it, and communicating those is important, but it's going to be hard, and just supporting each other. And that can be really critical. Okay, so I want to acknowledge about sharing client lists, because I said we're not going to talk about data systems, and you know, the enhanced care managers are going to get those member information files. I just want to acknowledge that sometimes people are rightfully afraid about things with HIPAA. It kind of can be this big black box. That I do want to say that under healthcare operations, for the purpose of care coordination, you can share minimal information. I put down the 45 CFR rule if anyone wants to look it up. If you're working in substance use disorders and behavioral health, the rules are a little bit different. They sometimes vary by state, so you know, be double sure on that, check. But really, the best first place to start is for people, once you've got your group, you know kind of where you're going to start, is for people to say you start with that, you know, member information file, and then people who may not be enhanced care managers, but they're going to be part of your cross-sector care team, show up at a meeting, and they also have their list of high needs patients. And whoever's facilitating the meeting, which has got to be someone consistently, that's just have to figure that out, is going to walk down that list, say the names, and figure out who in the room is also working with that person. And it seems slow and painful, but it works. And then you start adding that into your protocol and figuring out where the overlaps are, who's working with whom. And then that's when you start breaking off into those other sections, or figuring out how they all come together. And sometimes that's the best place to start until we have all this data ecosystem in place and you're easily sharing, and those still aren't going to be perfect. What is going to work is when there's a combination of a data coordination system and the human communication system. That's the only way it's going to work. But I just like to acknowledge that really you're going to have to do some sharing of lists that really is about just talking and saying, let's look at our top 30 people, or we've narrowed down the list to say we're going to start with the people who live within a 5-mile radius of Lincoln Avenue and are on the MIF list, you know, and this, and everyone, you know, run that same query in your systems, and let's see how many name matches we have. And then we'll know that we can make a difference on those folks. Something to that effect is really going to be one of your starting processes. There's not a magic wand for figuring out who's overlapping with whom. So, back to Maria. All right. So now, this is where it gets more interesting. Okay. So good news, you've built your cross-sector care team, because we just went through all that. You've built your cross-sector care team, and the enhanced care manager did a biopsychosocial with Maria and sat with her. And this is what they found out. It's a female, so the enhanced care manager. So she found out that Maria has lived with her mom for most of her life, except for when she lived with a friend for a few years. So they've lived together in this apartment for a long time. She's a fabric artist and she enjoys working with her hands. The highlight of her days are when she volunteers at the local elementary school teaching art, and she does not want her health to jeopardize this. She has a strong family history of cancer. She takes more than 10 medications and over-the-counter pills. She struggles from a lifetime of multiple chronic conditions. Of all her conditions, the lymphedema in her legs causes the most disruption to living her life and creates a lot of distress. Her screenings indicate moderate nutritional risk and high BMI. So that's a little bit more that you know about her. So the next thing that the enhanced care manager did with Maria is she wanted to set some goals. She wanted to find out what's important to Maria. Thinking most of you know about SMART goals. This enhanced care manager likes to use smarter goals. So she really said, what's important to you? Made sure they were specific, measurable, attainable, relevant, timely, and also said, what's exciting? What's going to keep you motivated? And what do you need to support you? What resources do you need? So she asked Maria, what are your goals? And this is what she came up with. And I don't know if you noticed, I specifically said what's important to Maria. And there's a big difference about what's important to Maria instead of what's important for Maria. It's important for Maria to lower her BMI. It would really help with her walking and her mobility. Is that important to her? I don't know. It's important for people who struggle with hoarding to have an accessible pathway if an EMT has to be called for a stretcher to get through their apartment. Is it important to them? Maybe, maybe not. So until it's important to them, they may not clear a pathway in their home. Lowering someone's A1C is important for them, but until it's important to them, they may not take those steps. So it's a really important difference in language, and changes may not happen until it's important to them. So what Maria said is mobility. That's really important to her. That makes sense. So Maria, you all wondered if Maria had been taking care of her mom. That makes sense. Her mom's been kind of taking care of her a little bit in some ways. So her mother has been wrapping her legs. She can't do it herself. So she can walk each day, but she's becoming unable to do so, meaning the mom. So Maria wants to keep getting leg wraps so she can maintain her functionality. So her lymphedema is bad. And she wants to keep volunteering at the elementary school. This activity is what helps Maria wake up each day, keep her going. It brings her joy. She fears that without her daily leg wraps or with other health failures, she will not be able to continue. So that's what's important to her. And I think, it's good to know. Okay, and so now that the enhanced care manager knows this information, she needs to go to her February cross-sector care team meeting, and she's trying to figure out what she can do because Maria has been going into the emergency room a lot. It's either, it's a lymphedema exacerbation, her breathing. There have been a lot of different reasons. So we need to figure out what to do. I don't know if it says it here soon, but also her mother just went on hospice. So mom's not going to be around much longer. So she's going to go into the meeting and, figure out what ideas does this cross-sector team have to help Maria achieve the goals that are important to her. Here are some folks that are on the team. All of you are going to be on the team, so you might have some ideas as well. And really, when you go into these cross-sector care team meetings, when you're planning, it's also a negotiation, a little bit of like, I think I can help with this, but I can't get to that. We've kind of been alluding to that this whole conversation. And so you're really going to go into this conversation and figure out what ideas do people have and how will someone know, like, I can call this person, but how can you help and who can do what? What do we think we can try? So I think that's an important step to kind of figure out what do we think can help with Maria and what are some next steps. So the enhanced care manager is looking for ideas and support because she's not quite sure what's going to be next. And always with every cross-sector care meeting, care coordination meeting, she always leaves with a plan. And this is critical. Never leave a meeting without knowing what are the next steps, who's going to do them, and by when. And that's really important. So what will keep her out of the ED? What will keep her spirits up? What will help achieve those goals of what's important to her? And who on the team can support it? So these are some of them. And how? We got to focus on those tasks. What are some hidden gems maybe no one's thought of yet? This group here is amazing. So I know you'll come up with some. And then make sure that it includes an agreement about some future actions. So if people don't leave that room with a time and a date and an action, it's definitely not going to happen. And then you follow up in writing. All right, so let's see what happens. So you all are now going to go into breakout rooms, and you're going to be on a cross-sector care team, and you're going to help figure out how Maria can achieve her goals. And really here in these teams, you're going to brainstorm some ways to help Maria meet her goals. And when you get into those teams, every group will have a member of the Phil staff in their room to answer questions. They'll also have a summary of all of Maria's information, so you don't have to have it memorized, as well as a team planning sheet. If you want to take notes on that, you don't have to. Feel free to ask them questions, but they're also going to be a part of your team, so they can help along. And I'm going to stay in the main room, so if anyone has questions, you can pop in and out of breakout rooms, as long as you can figure out the technology. So go for it. And, you have 15 minutes. If you come up with one idea, that's great, but make sure you have a plan. But brainstorm, see what you come up with, and just try it out. Now, does anyone? All right, so we'll keep going. So let's see what happened. Well, I'm just going to say one thing is, I always like to say when you're doing this kind of work to keep in mind for all the possibilities that flexibility is the key. That's not my quote. Explore bold ideas, listen, and see what solutions are possible. So to really keep an open mind to that. Okay, so here is what actually happened with the cross-sector care coordination team. These are not the actual partners that it happened with, but they are the right agencies or sectors that it did happen with. So what happened was, it actually kind of happened in sequential order, but they all had to communicate with each other. So like you're saying, the ECM couldn't do all of it by herself, but they did try applying for LTSS for a Medi-Cal waiver. She did not meet the criteria for that for a few reasons. And they tried to look for or to apply for skilled nursing services, but those were declined because she wasn't homebound. So you can't have home health come out and do the leg wrapping at home because she drives. So that wouldn't work. And then someone had the idea to what about private pay to have a nurse come out and do the leg wrapping. But that's, at this point, this was probably 6 or 7 years ago, $300 to $600 a month to pay someone to come out and do the leg wrapping. And there was no way that she could afford that. What ended up happening is in the ECM, we'll say, talk to primary care about getting PT help with it. And she qualified for outpatient PT because someone asked if anyone had ever shown her how to do her own leg wrapping. And they didn't think it was feasible just because of her health. She does have COPD. You're right about that. And she's large, so bending over to reach her feet seemed impossible. But what they figured out is that she could do her own legs. What she calls it is the sock putter on her thing device, but it's something that diabetics use a lot to put on their diabetic stockings. And it's an assistive, just funny, it's that tunnel shaped thing that you use to put on socks. And she learned how to wrap her own legs. And that's what happened. And it's interesting that no one had explored that with her before. So they never thought to teach her how to do it herself. So she didn't think it was even possible. She really thought she was going to end up living in a nursing home. And she had been approached about living in a nursing home or amputation. Those were her two options that she had heard about before. And I just added in here the fact that when you really look at it, I'm sure those of you who are in healthcare know about the costs associated with lymphedema-related hospitalizations and some of her other issues. So in the end, if someone had asked her sooner, do you want to learn how to do this yourself? And then really thought about it, there's a lot that can happen. And she's still volunteering. She's really happy and all that. So I think that's an important lesson. I think too, PTs play an amazing part. that's what I'm saying about thinking about possibilities, thinking outside the box with things. You never know. And I just want to acknowledge that I chose a little bit simpler, complex patient because we only have so much time today. I know a lot of you, all of us work with extremely complex patients, but the same principles apply. What are we not thinking of? Who isn't there? It's really, we have to challenge what we always do. And I was just talking with some colleagues, and I do think that often when I do these trainings, there are people from primary care often don't come who are RN care managers or have been doing care management for a really long time because they know how to do care management and they're really busy. But cross-sector care coordination is different than how you do care management every day in your own office. It's about how to work together and how to think differently. So I just encourage you all to share if some of your takeaways with colleagues about this teaming. So I just want to end with a couple of things and leave a few minutes for questions. On the left here of the slide is the official individual care plan. It's on Partnership's website, and I have that linked at the end. So this is what an ECM would fill out. And this would have Maria's goals on it. And when you get the slides, you can actually click on it. It'll take you directly there. I couldn't put the whole thing, but it's a sample and it's great. It's got everything you would want in an individual care plan. And if you want to make a comparison, the way you would think about that team planning sheet that you may or may not have used is think of it as like the care plan for your team. You've got to put as much thought and effort into that. This is just a sample one. You can use anything you want. But again, you really do have to take that time and effort into how your care team is functioning and what they're doing. And again, do the accountability, the SMART goals in that sense. That's what you want to do with your team if it's going to work, because you are all really busy and have a lot going on. And I don't want to say that it'll always be an ECM who is running the cross-sector teams, because it's going to be different for all of you. And I think that's going to be one of the follow-up steps after the asset mapping is what makes sense for different areas of who's coordinating these meetings. What does that look like? So those are some things. So just to summarize and bringing it all together, when you're going to build these teams, you really want to take time and recognize the broader context, check your perspective, your bias, your whatever you're coming in with when you come to the meeting, and think about what other people are coming in with and acknowledge it. Make sure you take that time to build the trust, safety, and really good communication. Bring in your flexibility, your openness, be willing to negotiate, because it's going to be a different process than what you do every day. Build a team and connect with the connectors and think about who's not there. Make sure you create a solid process that you can change over time, but you've got to start with something. And it's not ad hoc. And then leave with a defined action plan. So really work on that. One example, we, with one of our complex care teams that was cross-sector for a year, we met at the FQHC because that worked for everyone. It was a great location, good conference room, great parking. The ED social worker was our gem. She was on the team. She came when she could, which was once every 3 to 4 months, because she worked in the ED. Eventually, none of us wanted to meet at the hospital because the parking's terrible. It's in the middle of downtown. And it was just inconvenient. Eventually, someone said, how can we get her more at the meetings? She knows everything going on with everyone. And so we asked her what would help. And she said, can you meet at the hospital? That would really help me, because maybe I can run up there for 15 minutes and do a quick debrief, or I can come at the last minute or not come. And all of us were like, yeah, you're so valuable. We'll change it. We'll all deal with the terrible parking and driving downtown and all that stuff. And it made a world of difference. So, none of us thought of that. And it really made a huge, huge difference. These are the resources that I mentioned before. At the top is the Phil Path Collaborative and Implementation site. So there's all of the resources, all of the listening sessions, the facts. Stephanie, go ahead.
I have a quick question. It's related to the resource or the website. Meredith asks, will the team planning template be available on that website? Can we post this team planning template on the PATH website, on the
Yeah.
Phil PATH website? Perfect. So Meredith, yes. Thank you,
Yes.
Stephanie.
Yeah, no problem. And then the next one down, I keep referring to the trainings and the resources that Partnership has put together. So you can link to that from the Phil PATH website, or there's a direct link here. There's really, really good trainings that Partnership has done about with all of the nuts and bolts, all the details, care management, collective medical, the TAR, you know, all these nuts and bolts that I didn't go over because I'm not the expert on that, but they have done a really nice job there. Everything's linked. So check it out. I think it'll answer a lot of your detailed questions. This is more about the how of bringing it all together. Yeah, Zania, did you have a question?
Yeah, my question is, if we know that the PCP provider is not at the table, how are we to find out all of these other indicators that the ICP plan is requesting, like the A1C levels or the blood pressure? Is that just based on, is the ICP plan just based on the patient's perspective and goals, or is this all inclusive of their medical history?
I think that's a really good question. I think I'm going to get back to you on that. Partly is my first answer is we have to figure out how to get the primary care to the table. I do think it's really significant that there's not a lot of primary care here today. So that's something, it's a really good thing to figure out. And we want to look at collective medical too, to see what we can find out. And I don't know that off the top of my head, but let's get back to that. I think that's a good question. Because I also just saw the time and I want to let you all go. But thank you for asking that, because I think we have to make sure we have the right people at the table, and primary care can often be hard for good reason, but it can be hard. So the other reason, I won't go through them all, but these are just really good resources, whether it's around care management, care coordination in general, or just cross-sector work. So check them out. And then I was going to leave time for questions, but that didn't happen. So feel free to get in touch with me at any point if you have questions about this specific to cross-sector care coordination or individual care management. And of course, the Phil team is always there, and you can go to the website for more information. So I'm going to stop sharing, and I think we went a couple minutes over. I do apologize. But thank you all. Thank you for being willing to participate and really work things out. I think it makes for a rich training.
Thank you, Stephanie. Thank you, everyone.
Yeah, thank you.
Thank you.
Have a great day, everyone.